So today we are discussing the male and female reproductive systems. We won't get into pregnancy, growth, or development until the next chapter. So some pretty general terms to know are the gonads. So know the primary sex organs are the gonads. This is on your quiz. For males, these are the testes, and for females, these are the ovaries. They produce our gametes or sex cells. So the ova or eggs and the sperm, respectively. Gonads are, they also secrete our sex steroids or sex hormones. We call these androgens in males and then estrogen and progesterone in females. So know the sex steroids or sex hormones. That will also be asked on the quiz. And then we've got our accessory reproductive organs, which we'll talk about in detail. Ducts, glands, external genitalia. So what role do sex hormones have? They help develop the actual sex organs. Babies have these organs, but they are not ready for reproduction. So the organs are there, the sex hormones help mature them, and then as you age, they'll perform the functions of an adult male or an adult female. So sex hormones also help to instill sexual behaviors and drives as you get older. Sex hormones also help in growth and development in many other organs and tissues. If you remember all the way back to the endocrine chapter, we mentioned that estrogen plays a role in both bone growth, for example, and then testosterone helps in muscle development. So here is where all that hormone information gets discussed a little bit more in depth. I know it's been a while since we talked endocrine, but here we go again in male and female reproductive systems. So we're going to talk male reproductive system first. We have the testes. They reside inside the scrotum. The scrotum is the sac that hangs outside of the body, and the testes produce the sperm. So the reason testes hang outside of the body instead of tucked inside like ovaries in females is because if the testes get too hot, that increased temperature can kill the sperm. That is a problem that females don't have with eggs. That being said, guys wearing tight jeans, that can kill some sperm, but not enough to act as a viable contraception method. So, to both give fact behind the urban legend and to debunk the urban legend at the same time, tight jeans can kill some sperm, but it's not going to kill all of the sperm. You can still get someone pregnant. So anyway, sperm get delivered to the outside of the body through a whole system of ducts. So memorize these ducts in this order for the quiz, okay? Epididymis, ductus deferens, they are also known as vas deferens, same thing, ductus or vas deferens, ejaculatory duct, and the urethra. We will talk about these individually as well, but you will need to know them in this order. You will be asked to label first to last. Okay. Then we have our accessory sex glands of the male reproductive system. These are seminal vesicles, prostate, and the bulbourethral glands. They were also known as Cowper's glands back in the day. Now we call them bulbourethral because of their location. You'll see their location in a second. It'll make sense. They're bulb-shaped. They're near the urethra. And we'll talk about those more specifically as well. So we're looking at this image. We're only going to label some of this stuff. It'll be what's highlighted in blue. So I have the ureter up here, going down into the urinary bladder. Seminal vesicles are back here. Ejaculatory duct leads out of that. What else? We've got the rectum. That leads down into the anus. Prostate, that's around the urethra. And we've got the see, prostate right there, bulbourethral gland sitting right there, behind the urethra. It's bulbous. We already said anus, the vas deferens, right here. So all of that is the vas deferens. Then you have the scrotum, sac. Vas deferens are actually inside the scrotum as well. Lead to the testes right there. What else? Oh, and then the epididymis between the vas deferens and the testes, or the vas deferens lead into it, but it encapsulates basically the testes right there. And that's all. I think I said it all. Seminal vesicles, ejaculatory duct, the rectum's right there, anus, prostate, bulbourethral gland, anus, already said that, vas deferens, boom, testes, scrotum, epididymis, and the ureter's right there, the urinary bladder. And yeah, and then the urethra. Okay, moving on. So the scrotum, like I said, that's the sac that hangs outside of the body. It houses the testes. It stays at a temperature that's 3 degrees Celsius lower than your core body temp. That's what's necessary for sperm production. The penis is 3 parts, root to shaft to glans penis. The foreskin, it gets cut off during circumcision. Most of the penis is spongy. It's a spongy network of connective tissue and smooth muscle with a ton of vascular spaces. When these tissues fill with blood, that's what causes the penis to enlarge and stiffen. This process is known as an erection. So now the tubing. So know the pathway. Like I said, epididymis, ductus, or vas deferens, ejaculatory duct, and the urethra. So you'll hear me say vas deferens probably because that's what I'm used to saying, but it's the same thing as the ductus deferens. Anyways, non-motile sperm enter, pass slowly through, and they get motile as they go. So motility means movability, right? New sperm are not swimmers. Once they go through all the tubing, that's when they become swimmers. If for some reason they are not motile, once they go through all that tubing, then they will never swim, and they are a giant cause of male infertility. So sperm that can't swim. Anyways, so the sperm gets through the tubing, and during ejaculation, the epididymis contracts and expels sperm to the ductus or the vas deferens, which is just a tube. The epididymis is for storage until you need the sperm, and then the vas deferens is just a tube that moves it. So sperm is moving through the vas deferens and passes through the inguinal canal. So that's where doctors check you for a hernia to kind of give you an idea of where that's located. Then the sperm goes from the epididymis into the urethra. Again, know that pathway of sperm through the male reproductive system. So start at the epididymis, through the vas deferens, through the ejaculatory duct, and into the urethra. During a vasectomy, a tiny incision is made under the scrotum. So the vas deferens get pulled out, clamped at both ends, cut or ligated, or cauterized in some instances. And this is almost 100% effective form of birth control. So this can be reversed, but reversal is more complicated, and it runs the risk of scar tissue buildup, and it isn't guaranteed. So know what gets cut and what gets ligated during a vasectomy. Those are the vas deferens. So let's go back up here to the picture. So testes, epididymis, vas deferens, all the way to the urinary, to the urethra, and out. Okay. We were just here. Okay. So I showed you that it goes through the urethra. So the urethra in males conveys both urine and semen, but it only does so at different times. So males cannot urinate and ejaculate at the same time. So this is going to be on your quiz, that the urethra in males conveys both urine and semen. Fun fact, male urethras are a lot longer than females, so they have less risk of UTIs, urinary tract infections, because they'll pee out the bacteria before it has a chance to make it all the way up the urethra. Females, and then into the bladder and into the urinary tract, kidneys, everything. Females are not so lucky, especially because they have shorter urethras, right? So they have to make sure, females have to make sure that they pee after intercourse to help flush those bacteria out, because bacteria are fast. They are gonna go up into that urinary tract as fast as possible. So to prevent the risk of UTI, it is very, very necessary for the ladies to urinate after sexual intercourse. Accessory glands, seminal vesicles, so they produce an alkaline or basic, so not acidic fluid. This fluid consists of fructose, which is sugar, ascorbic acid, which is vitamin C, and an enzyme to make liquid and thicken that liquid. And then prostaglandins, which are pro-inflammatories. This is basic fluid, so this is alkaline seminal fluid to offset the acidity of the female vagina. And seminal fluid makes up about 70% of the volume of semen. So that's a lot. 70% of semen is the seminal fluid. All right, so the accessory gland, prostate. So prostate is that donut shape that encircles the urethra I just showed you. It sits underneath the bladder. So if it swells up, it pinches the urethra and it does not allow urine to come out. And that's usually when males understand that there's something wrong. The liquid that comes out of the prostate is a little bit acidic. It contains citrate. Enzymes, and PSA, which is prostate-specific antigen. PSA levels are the ones that are checked in blood work to see if levels are normal or elevated. If elevated, then there's a probability of enlargement, and it gets treated for that. Prostate enlargement can be called prostatitis, which is inflammation of the prostate. And higher PSA levels can also be indicative of prostate cancer as well. So it's really, really important for males to get, those levels checked out, get their prostate checked out, and everything there. Unfortunately, the easiest way for the prostate to get checked out is through the rectum. But moving on, checked out for swelling. Anyway, moving on, the fluid goes from non-swimmers to swimmers. It's secreted by the prostate, and the prostate plays a role in sperm activation, right? So getting that fluid to go from non-swimmers to swimmers. And it enters the prostate, or it enters the urethra during the ejaculation process and not beforehand. And then we have the bulbourethral glands, also called the Cowper's gland. They are tiny little glands below the prostate. You can't feel them. They're tucked inside the pelvis. Prior to ejaculation, they produce a thick, clear mucus, and that helps in lubrication, and it helps neutralize any traces of leftover urine within the urethra itself. So it helps neutralize so that the urethra, so you're not flushing any urine into your partner during ejaculation. Semen is a mixture of sperm and all of the gland secretions that we just went over. Semen contains fructose, and it protects and activates the sperm, and it helps facilitate their movement. So if there were no liquid, there'd be nothing for the swimmers to swim in, and relaxin helps to get the sperm moving as well. Relaxin also causes the cervix end of the uterus to relax so that it opens more to let sperm get in. Prostaglandins in the semen, they lower viscosity of mucus in the cervix. So unless a female is on her period, there's a mucus plug that seals up the uterus and sperm cannot penetrate it, can't get through it. Prostaglandins help thin that out so sperm can get through. Plus, prostaglandins also help stimulate reverse peristalsis in the uterus. So peristalsis is that wave-like motion of smooth muscle. Reverse peristalsis is that same muscular contraction but backwards. So normally in females, peristalsis would be from the top of the uterus to the cervix, like when shedding the lining during menstruation, right? From the top to the cervix, out through the vagina. Well, in this case, reverse peristalsis is causing the wave to go up into the uterus instead to help sperm swim up toward the uterus. For the purposes of getting tested over this, know the purpose of the mucus in the cervix. And we'll talk about that more later as well when we talk about female reproductive system. So I've already said that alkalinity neutralizes the acid in the male urethra and the female vagina. There are antibiotic chemicals in semen as well that destroy certain bacteria that can kill sperm, which is good. There are clotting factors that coagulate the semen just after ejaculation. And then there's another one called fibrinolysis that liquefies it. So if it's thick until sperm can get right up to the surface, that's good. Then we need something to thin it out enough for sperm to be able to actually swim. And that's what that does. Of all semen that's ejaculated, which is about 2 to 5 milliliters, there are 20 to 150 million sperm per milliliter. But note this, and this is going to be on the quiz, semen function does not include actually producing viable sperm. So, that's important. Anyways, only one viable sperm is necessary for female pregnancy to happen. And there are millions making a very, very long journey in hopes of one sperm making it to get to fertilize an egg, right? So some people can get pregnant immediately. Others can take years and years and years. If you're not trying to reproduce, then please take precautions. Male sexual response, this is initiated by stimuli like touch, mechanical stimulation, sight, sound, smells. It can be induced or inhibited by emotions or higher mental activity. So you can think your way into or out of ejaculation. But the male sexual response is stimulated by a bunch of stuff. You'll notice that females are a little bit different. Erection. It is possible to have an erection without ejaculation, for those of you who are wondering. It can be very painful for guys, though, for males. So what we have as far as the erection process goes, the parasympathetic system, so rest and digest, promotes the release of NO, which is nitric oxide. It's not no, that would be capital N, little o. This is capital N, capital O. So nitric oxide. It causes erectile tissue to fill up with blood. So you'll have to know this. You'll have to know that nitric oxide causes engorgement of tissues. You will be asked. So where are we? Expansion of the corpora cavernosa. So big opening in the body of the penis. It compresses the drainage veins and maintains engorgement. So it lets blood in, but it does not let blood out. Corpus spongiosum keeps the urethra open. So erection stays and the urethra is open for semen to exit. Conversely, impotence is the inability to attain or to keep an erection. You can get one, but not for very long. So, be able to define impotence. Ejaculation is the propulsion of the semen from the male duct system, and it's a sympathetic spinal reflex. So parasympathetic for an erection and sympathetic for ejaculation. So both halves of the nervous system are kicking in here. So the ducts and accessory glands contract and they empty the contents. The bladder sphincter muscle constricts so that you don't urinate at the same time. And the bulbospongiosus muscle undergo a rapid series of contraction. So these series of contractions are very regular and they actually match up perfectly with female uterine contractions, which is pretty interesting. They co-align. Contractions exactly match up. Spermatogenesis, so the making of sperm in the seminiferous tubules of the testes. Most body cells or somatic cells contain 23 pairs of homologous chromosomes, so 46 total chromosomes. Gametes or sex cells are a little bit different. Sperm contains only 23 chromosomes, so not 23 chromosome pairs like most body cells or somatic cells. Soma means body. There won't be a pair with sperm until a sperm pairs with an egg. So 23 chromosomes of sperm, and then you're going to see the same thing with an oocyte or an egg, an ova. Homologous means same type of chromosome, by the way. You get one set from your dad, one set from your mom, which equals 46. But until those two come together, it's only going to have 23 chromosomes. It's not going to have 23 pairs until it pairs with an egg. So that's an easy way to remember that. Don't get confused about that. Major regions of the sperm are the head, the midpiece, and the tail. So the head has a nucleus inside of it and a helmet-like acrosome. Acrosome just means head or top. Soma, body. Acro, head top. Soma, body, acrosome. So the acrosome, like I just said, is the tip of the body of the penis. Or, I'm sorry, not the penis, the sperm. Head, midpiece, tail of sperm. Acrosome is the head, or the head contains the acrosome and a nucleus. It also has enzymes that allow it to burrow through or penetrate through to the egg so it can fertilize it. Then we have the midpiece. So that has the mitochondria. What's the mitochondria? The mitochondria is the powerhouse of the cell. So the midpiece is going to be the powerhouse of the sperm. And it's going to provide the sperm cell with the most energy. So write that down. Midpiece has the most energy, provides the sperm with the most energy. It moves the tail and it propels the sperm. So then we have the tail, and it's a flagellum, which just means it's whip-like tail. It makes little figure 8 whips with its tail. But the midpiece is what actually gives it that oomph, that energy to go, go, go. So this is a good picture. Spermatid is an immature sperm. And then it goes through its maturation period. And then here we have the midpiece, the midpiece, the head, and the tail. So the tail is the longest. The midpiece is what provides that tail with the energy. And then the head that punctures through the egg to fertilize it. So you'll have to be able to list the sequence of hormones from first to last. Short version is gonadotropin releasing hormone, then follicle stimulating hormone and luteinizing hormone, then testosterone, then inhibin. So let's talk about them. This has to happen in this sequence for sperm to be made. So first, the hypothalamus releases gonadotropin releasing hormone, or GnRH. GnRH stimulates the anterior pituitary to secrete follicle stimulating hormone and luteinizing hormone. Follicle stimulating hormone, or FSH, causes sperm cells to accept testosterone, so spermatids must be receptive to testosterone if they want to mature into a sperm. And that's where FSH is super important. And then LH, luteinizing hormone, stimulates that release of testosterone. That kind of happens simultaneously with FSH and LH. Testosterone is the final step for spermatogenesis, or making of sperm, and then feedback inhibition from the hypothalamus and the pituitary results from rising levels of testosterone. Inhibin, which released when sperm cell count is high, causes. Let me restate that. So when you're making when you've made enough testosterone, GnRH is gonna stop and LH is gonna stop. It's gonna get inhibited. When sperm count is too high, inhibin shuts off GnRH and FSH. So remember the sequence. GnRH is first, FSH and LH are second, testosterone is third, and inhibin is fourth. So GnRH stimulates the secretion of FSH and LH. FSH causes sperm cells to accept testosterone. LH stimulates that release of testosterone. And then inhibin stops everything when there's enough. Okay. So what all does testosterone do? So it's made from cholesterol, so you must have cholesterol in your diet to make steroid or sex hormones. And testosterone is one of those. Testosterone affects DHT in prostate and neurons in the brain. It prompts the making of sperm. Low testosterone levels can be linked to low sperm count and infertility. Testosterone has multiple anabolic effects through the body, so it helps build muscle, helps you bulk up. To remember this, think anabolic steroids in sports and how they're illegal, because they are helping to bulk up muscle in a way that's not allowed in sports. And they're not allowed for a reason. They have a lot of various side effects as well. But anyways, testosterone has multiple anabolic effects throughout the body, and it's the basis of the sex drive, the libido in males. Some males' secondary sex characteristics are induced mainly by testosterone. Appearance of pubic hair, armpit hair, facial hair, enhances growth of chest and deepening of voice. Skin gets thicker, skin gets oilier, bones grow and increase in density, and skeletal muscle increases in both size and in mass. And now we move on to the female reproductive anatomy. So that ends the male section. Now we're moving on to the female reproductive system. I'm going to get a little drink of water. So ovaries are the female gonads or primary sex organs. Ova are the female gametes or sex cells. Ovaries produce ova and secrete estrogen and progesterone, which are our female sex hormones. Estrogen continues the cycle, progesterone continues the pregnancy, an easy way to remember that. Then we have some accessory ducts, again, ducts, tubing. We have uterine or fallopian tubes. We have the uterus and the vagina. These are all mainly just passageways for sperm to get to the egg and places to carry the zygote, the fertilized egg. So know the items here in blue. So got the rectum and the anus, and then we have the vagina over here. We have the greater vestibular or Bartholin's gland here. Labium majus is the outside lips, labium minus inside. It used to be called labium minoris and labium majoris. That has changed to labium minus and labium majus. Clitoris is going to be right here, right here on the clitoris. The urethra is right there, leads to the urinary bladder. Uterus is this right here, and then we have the ovaries up here and the uterine or the fallopian tube right there. And that's what you need to know. Ovaries. So know this part. Know that the broad ligament supports the uterine or fallopian tubes, the uterus, and the vagina. And it's what prevents the ovaries from descending like testes. You'll be quizzed over that. We're going to touch on that again. The broad ligament does a good job, but during pregnancy, if you gain a lot of weight or are larger and weigh more, the broad ligament might not be strong enough, might not work so well. When that happens, it's what is called a prolapsed uterus, and it will hang or bulge out of the vagina. So a fun fact, if you will. Anyways, vesicular or Graafian follicles, these are fluid-filled follicles that bulge from the surface of an ovary. So do you remember the picture of polycystic kidney disease where I talked about ovaries and shared the polycystic ovary picture with the bumps and all the blisters? So each of those was a vesicular follicle. During ovulation, one of those follicles is matured throughout the month, and the egg or oocyte, which is an egg cell, grows inside of it, and it gets popped out. Once the egg literally explodes out of the follicle then shrivels up and is called a corpus luteum, which means corpus is body, luteum is yellow, so it's a yellow body. And that develops from a ruptured follicle after ovulation. Ruptured follicle means the egg exploded out of it. You're going to see a picture of that in a second. And that becomes important for sustaining a pregnancy. So this is a cross-section of an ovary. So putting all of those words I just said into a picture. So you've got all these little baby follicles right here that you're born with, and over time they gradually increase in size. This one is ready to go next month probably. This month though is right here. You see how this egg is popping right off? It's exploding out. This follicle itself then shrivels up after the egg explodes out of it. And this is a developing corpus luteum right here. And now this is a developed corpus luteum right there. And it's going to start making some hormones shortly, which we'll talk about later. And if there's no pregnancy, it actually shrivels up into this that we call a corpus albicans, or a white body, if you will. So that's the whole process from these little baby follicles maturing until they pop out of the follicle, develops the corpus luteum. Corpus luteum then dries up into corpus albicans. Okay. Uterine tubes or fallopian tubes, they have ciliated fimbria of infundibulum, and that creates currents to move oocytes into uterine tubes. So what does that mean? So cilia are tiny hairs, fimbria are like little fingers, and at the end of the fallopian tube you have small finger-like projections with cilia or hairs that help move the loose egg that just popped out of that follicle into the tube, so that it goes down the tube and into the uterus. The oocyte, it's carried along by peristalsis, which we just talked about, wave-like motions of smooth muscles, and you've got more cilia in the fallopian tubes, so the oocyte keeps getting pushed along and pushed downward. And then there are some non-ciliated cells inside the fallopian tubes, or uterine tube, same thing, that nourish the egg or oocyte. So it doesn't die, and when the sperm makes it, the oocyte gets nourishment from the sperm as well. Or I should say, if the sperm makes it, to fertilize that egg. So moving on to the uterus. The cervix is the lowest end of the uterus. It is a narrow neck and it projects into the vagina. You can actually feel the cervix. It's like a small donut about the size of the end of your thumb. And you can see it too if you get a mirror and move the labia out of the way. A gynecologist does a pap smear or pap test by removing some of the cervical cells to screen for cervical cancer. The cervical canal communicates with the vagina at the external os, which is the external opening. And then there's a second opening on the inside, so kind of like a double sphincter. And the cervical glands secrete mucus that blocks sperm entry, except during mid-cycle, when the mucus thins and the vagina secretions change, and that's the most fertile time. So mid-cycle is what we call ovulation. Ovulation is the most fertile time. The uterus itself is, it has 3 layers. It has the perimetrium, which is the serous layer, the outside covering layer. The second is the myometrium, the smooth muscle layer responsible for contractions during menstrual cycle, aka cramps, and during childbirth. So know that. Know the myometrium for the quiz. And then lastly is the endometrium, which is the most innermost layer. You guys have heard of endometriosis? Endometrium. Mucosal lining, innermost layer. The vagina, it is both the birth canal and the organ of copulation, so double duty with the vagina. It extends between the bladder and the rectum from the cervix to the exterior. So the first hole from the anterior surface would be the urethra, the second would be the vagina, and the third would be the anus. The vagina is the middle hole, the urethra is the first. And the urethra is embedded into the anterior wall. So unlike the male anatomy, females can actually urinate during sex. External genitalia, females have a clitoris, which is a small erectile tissue like a mini penis, but nothing comes out of it. It has a tip on it, just like the penis, and is very sensitive, and that's the part that you can see. The glans clitoris is the exposed portion. So here's a little picture of this, the female perineum. So you can see the clitoris there at the top, the urethral opening right here, the vaginal orifice, and then the rectum, the anus would be right behind that, below that. Mammary glands are modified sweat glands, so babies drink modified sweat. Sounds gross, but it's super healthy, and we call it milk. We'll talk more about it in pregnancy as well. The areola is the pigmented skin around the nipples. There are lobules that you're going to have to know what they do on the quiz. The lobules are within the lobes that produce milk. So think of an orange with orange slices. They all come to a center point. Same with mammary glands arranged in the breast by lobules. So you'll see a picture in a second. So those sections are called lobules. And they arrange the mammary glands. They produce milk and they funnel it all the way to the end. So milk is made, it goes to the lactiferous ducts, then the lactiferous sinuses, where it's held until the baby is ready to eat, and then it opens to the outside at the nipple. So here's a visual. So notice though that there is a hole for each lobule, right? In the middle of the breast. It's not just one opening in the center of the nipple. There are a bunch of little openings heading towards the middle of the breast. See right here? This is a better picture. Opening of lactiferous ducts right there. Boom, boom, boom. Breast cancer. So please notice that risk factors do not include injury to the breast. Will you be asked that on the quiz? Probably. Anyways, injury to the breast is not a risk factor in breast cancer. Risk factors do include early onset of menstruation and late menopause. Risk factors can also include never having a pregnancy or having your first pregnancy very, very late in life. And then, of course, family history of breast cancer can increase your risk for breast cancer. 10% of all breast cancers are actually due to hereditary defects. So doctors will actually test BRCA1 and BRCA2 genes to see if you are at risk for breast cancer. And if you are, there are steps that you can take. And some women actually go ahead and get their breasts removed. Christina Applegate is an actress that actually did get her breasts removed whenever they did find that gene, because if I'm not mistaken, she did have her mother die of breast cancer, and she just didn't want to put herself or her family at risk of losing her to the same thing. So she went ahead and did get her breasts removed when doctors found that she did have mutations to those genes. And some women do that. They just go ahead and eliminate the risk by getting their breasts surgically removed. 70% of women, they have no idea because they have no risk factors and they don't know why they ended up getting breast cancer. That's where self-examinations and mammograms are super important. And then treatments are going to be really dependent on the characteristics of the lesions, how far the cancer has spread, etc. And then, treatments do include radiation, chemotherapy, surgery, followed by irradiation, more chemotherapy, etc., etc. And preventative screenings happen with mammograms. This is a picture between a normal breast with all of the lactiferous ducts that you can see versus a malignant one. It doesn't look too different. I wish that this wasn't highlighted in yellow so you can kind of see the clusters a little bit better without it being so, obvious. But you want to look at the ducts and you want to look at the thickness of the ducts. They should feel like a little tiny ball. And interestingly enough, it's usually not the woman that finds her own tumor, but her male partner in most cases. But if you ever do feel any bumps or anything weird, it's still recommended. Or if you do feel anything, any bumps or anything that shouldn't be there, get it checked out. Maybe it's that you have more fibrous breast tissue. Maybe it's not going to be a tumor, but it's better to get it checked out than to not. And then if you never feel any bumps and you never have any problems or feel anything weird, it is still recommended for females to start getting mammograms yearly at the age of 40, or to begin them at the age of 40 and then do them once a year. So here we have, again, with follicular and luteal. We have the ovarian cycle, which is a monthly series of events associated with the maturation of an egg. So there are 2 consecutive phases in a 28-day cycle. We have the follicular phase on day 1 through day 14. Then at mid-cycle, we have ovulation. And then we have the luteal phase at days 14 through 28. So the follicular phase, day 1 through 14, that's a period of follicle growth where the egg explodes out of the follicle and starts ovulation. So ovulation is going to be when you're most fertile, and we call it mid-cycle because it occurs at the middle of your cycle. So the egg has popped out of that follicle, you are super fertile, you are ovulating, and then you start your luteal phase at day 14 through 28, where the follicle turns into that corpus luteum, that yellow body that we saw. At ovulation, there's a term called a Mittelschmerz, and some females can feel a twinge of pain when the egg pops out of its follicle on one side of the body only. So that indicates which side, left or right ovary, the egg popped out of. So because you usually alternate sides back and forth between the ovaries as to which one is fertile, If you are someone where only one ovary works, then you're only capable of getting pregnant like every other month. Or at least your chance of pregnancy decreases by 50%. It's not always left side this month, right side this month. Sometimes it's left this month, right this month, left this month, right, left, right, left, right, left. You know, it's not always so consecutive, but usually they do alternate. But anyways, if only one of your ovaries is viable, then, you know, your chance of pregnancy is obviously cut in half. 1 to 2% of ovulations release more than one secondary oocyte, which if fertilized results in fraternal twins. So if the left and right ovary both release an egg that month, you get fertilized, you could end up with fraternal twins. Very rare. If two sperm... No, never mind. Let's move on. Luteal phase. So the egg has ruptured, the follicle collapses, turns into the corpus luteum, or like yellow body. And the corpus luteum, I told you, was going to start secreting some stuff. Well, it starts secreting progesterone and estrogen. So it's prepping the way just in case you get pregnant. If no pregnancy happens, then the corpus luteum degenerates into that corpus albicans we just saw. And it takes around 10 days. So it shrivels up, no longer makes estrogen or progesterone, and your cycle starts over. Now, if pregnancy does occur, it takes over the hormones. The corpus luteum produces hormones until the placenta takes over at about 3 months. So what can happen in the first 3 months? The first trimester, if you will. What can happen pretty commonly? A miscarriage. So a miscarriage can occur if the corpus luteum shuts down too early, or if the placenta isn't developed enough and it's not ready. And there's a dip in progesterone, which you need to carry a pregnancy, right? Progesterone is the pregnancy carrying hormone. And then if that, like I said, if that dips, then miscarriage occurs. So now let's discuss hormonal interactions during a 28-day cycle. So first 2 weeks is the follicular phase. Mid-cycle is ovulation, and the last 2 weeks is the luteal phase. Let's see what's happening with the hormones during these phases. Day 1. So same as in males, gonadotropin releasing hormone releases, or stimulates, blah blah blah. Anyways, to release FSH, follicle stimulating hormone, and LH, luteinizing hormone. FSH and LH, they grow several follicles which are at different stages of development. So it stimulates different phases of maturation of those follicles. So remember the image earlier where I said that one's probably ready in about a month or so. And then we had the one egg that was bursting out of the follicle. Well, this is what causes that. So FSH and LH, they grow the follicles and release estrogen. Estrogen goes up because FSH and LH So estrogen levels go up, and they inhibit the release of FSH and LH, so they stop making it. Well, when your egg is released, you don't need that estrogen as much anymore. So your estrogen levels actually need to go back down and not up anymore. So once you ovulate, then that turns FSH and LH off. And it stimulates the synthesis and storage of these because we'll need them again, just not right now. And then eventually that'll enhance further estrogen output because we're controlling our estrogen levels by both stimulating and inhibiting follicle stimulating hormone and luteinizing hormone. So estrogen then continues as the follicle increases. High estrogen levels have a positive feedback loop. So the estrogen keeps building and keeps building and keeps building up until day 14 when the follicle matures and the egg pops out and your estrogen levels need to take a dive. Day 26 through 28 is the end of that cycle. Corpus luteum is degenerating and hormone levels are decreasing, and you're at the end of the cycle. You're going to have a period soon, and that ends the blocking of FSH and LH, and then the cycle starts over again. Here's a visual. Know that the 2-week follicular phase is followed by the 2-week luteal phase, and that the mid-cycle is ovulation. And this is just a picture of that 28-day cycle. With the primary follicle, secondary follicle, vesicular follicle, ovulation, corpus luteum, degenerating corpus luteum, and a corpus albicans there at the end. That's our ovarian cycle. Anyways, you will be quizzed over follicular phase, ovulation, luteal phase, but know that 2-week follicular phase is first, and it's followed by the 2-week luteal phase. Don't get ovarian cycle confused with the uterine or the menstrual cycle. We just talked ovarian cycle. That's the cycle of making an egg, oogenesis, and releasing an egg. And now we are on to the uterine menstrual cycle. So this is a cyclic change in the endometrium in response to ovarian hormones. And there are 3 phases here. So know these 3 phases and know how many days are in each of these phases. Day 1 through 5, day 6 through 14, day 15 through 28. So day 1 through 5 is actually the menstrual phase. So the shedding of the lining is actually happening on day 1 through 5 at the beginning of the cycle. So here's where we're cleaning out, starting over. Day 6 through 14 is the proliferative phase or the pre-ovulatory phase. So you haven't had ovulation yet. And then day 15 through 28 is the secretory phase or the post-ovulation phase, where you're building up the lining just in case you get pregnant. The lining that you shed out day 1 through 5, you're rebuilding in day 15 through 28 just in case pregnancy occurs. Menstrual phase, day 1 through 5, or ovarian hormones are at their lowest levels. Estrogen and progesterone is low. Your body is not having a baby, and that functional layer, the endometrial layer, sheds, and that's the menstrual blood flow. Then we have the proliferative phase, so day 6 through 14. Estrogen prompts a new lining layer, so you're building your progesterone back up and building that endometrial layer. And then the secretory phase, day 15 through 28, that's when progesterone levels are at their highest. So you're further developing the endometrium in case a fertilized egg comes down and needs some place to go. And the progesterone also makes a cervical mucus plug so that you don't lose the zygote through the cervix. Here's a graph of fluctuating estrogen and progesterone levels over that 28-day cycle that we just talked about. So the first phase, the second phase, and the third phase, right? And this just gives a little picture of it. Days 1 through 5, days 14 through, or days 5 through 14, and days 15 through 28. And here's all that's graphed and reiterated. Here's all of that graphed and reiterated. But this is everything we just talked about. So your menstrual flow is right here. Your levels are pretty low with estrogen and progesterone. Day 1 through 5. Then we have our proliferative phase here. Day 5 through 14. And then day 15 through 28 as our secretory phase. 3 phases. Menstrual, shedding of the functional layer of the endometrium. Proliferative, rebuilding of the functional layer of the endometrium. And then secretory begins immediately after ovulation. Enrichment of the blood supply and glandular secretion of nutrients, preparing the endometrium to receive an embryo. So both menstrual and proliferative phases are for the ovulation, which is mid-cycle, and then together they correspond to the follicular phase of the ovarian cycle. And then the secretory phase corresponds in time to the luteal phase of the ovarian cycle. So you can see how uterine cycle and ovarian cycle are similar, but do not confuse the two. They correspond in time. They are similar, but not the same. Okay. So if fertilization does not happen, then corpus luteum degenerates into corpus albicans, progesterone levels decrease, and spiral arteries in the uterus lining, they will kink and spasm and make that layer die, so no blood flow to the lining of the uterus, and that's why it sheds. And then a rush of blood fragments weaken the capillary beds, and the functional layer sloughs off, and that's what period blood or menstrual flow is. Effects of estrogen, so it makes the egg oogenesis, it makes the egg grow, makes the follicle grow, it matures the organ of the female reproductive tract, and it supports the fast but short-lived growth spurt at puberty. Estrogen also induces secondary sex characteristics like breast growth, curvy body, so hips and breasts, pelvis gets wider in case of pregnancy and causes more, of that hippie sort of build. Pre-puberty, hips are turned in and narrow, similar to boys, but then estrogen changes that. Metabolically, estrogen maintains a low total blood cholesterol and a high HDL level. HDL is the good cholesterol, remember? And then during menopause, that unfortunately flips. Also, estrogen facilitates calcium uptake, helps calcium come out of the blood and into the bones. So that is another thing that struggles during menopause, where you don't have as much estrogen happening. Effects of progesterone. So progesterone and estrogen work together to establish and regulate the uterine cycle. They trade out at day 14, like we talked about. Effects of placental progesterone during pregnancy. Inhibits uterine motility. You do not want uterine contractions during pregnancy. It also helps prep breasts for lactation. And then female sexual response. So with guys, remember, it was all about smells, touch, thought. With females, it is also initiated by touch, but more so by psychological stimuli. The clitoris, vagina, and breasts engorge with blood. The vestibular gland secretions lubricate the vestibule. So if they don't, then there is dryness, and there can be pain during intercourse. For both parties, that can tear those really soft tissues. Medicines that dry up mucus, like cold medicine, it will also dry up vaginal mucus. So think about that and use some other forms of lubrication so that you're not hurting yourself or your partner. Orgasm is accompanied by muscle tension, increase in pulse rate and blood pressure, and rhythmic contractions of the uterus. So those rhythmic contractions are at the same rate of contractions in males. So they match up in males and females, which is really cool. There is no refractory period for females, so females can have multiple orgasms back to back. Males do have a refractory period, and they do have to have time off to build another erection. How much time off is just dependent on person to person. But now, do note that orgasm is not essential for conception. So, don't have to orgasm to fertilize and reproduce. Alright, and then a little bit of developmental aspects, sex chromosomes. So 1 out of the 23 pairs, actually the 23rd pair of chromosomes in the body cells, are the sex chromosomes, X and Y. Females are XX. Each egg has an X chromosome, and then males are XY. So there's 50% chance of sperm containing the X chromosome and 50% containing the Y chromosome. So females only contribute X, males contribute an X or a Y. So males are the ones really that are determining the sex of the baby. So XX, female offspring, one X on the egg, one X on the sperm, female offspring. Females always contribute an X. If a male contributes a Y, boom, XY, male offspring. Pretty easy. That's pretty easy stuff. Sorry. Where are we? Okay. Descent of the gonads. So 2 months before birth, testosterone stimulates migration of testes towards the scrotum. Ovaries also descend, but remember, they are stopped by the broad ligament and they don't pass that at all. Whereas testes do migrate outside of the body. Gubernaculum is the fibrous cord from each testis to scrotum, or from the ovary to the labium majus. That's what helps guide the ovaries and testes downward. Gubernaculum, pretty fun word. A consequence of undescended testicles is infertility. So do note that one. That one might show up on your quiz. That a consequence of undescended testicles is infertility. Menopause. So menopause happens when menses has stopped for an entire year. So 1 year, know that for the quiz. Menopause happens when menses has ceased for an entire year. There's nothing equivalent to menopause in males. They can actually make sperm and reproduce until they die. Females are conversely born with all the eggs that they'll ever have. So by 50 or so, they're going to be out of good eggs and they're going to be hitting menopause. Now, that's not to say that males don't go through a midlife crisis where some of their testosterone levels and such change. They don't actually go through something that's going to cause them to stop making sperm, because they make sperm until they die. Some declining estrogen levels can also cause atrophy of reproductive organs and breasts. Irritability, depression can happen. Hot flashes as vessels vasodilate. That happens really, really fast. It's a quick onset during intense vasodilation. Gradual thinning of skin, gradual bone loss, and then increased total blood cholesterol levels, which we don't want, and falling HDL, which we don't want. Can also happen in menopause. And that is it for the male and female reproductive system lecture.